did this huge, yeah, in the picture, they did this huge, like, thing on the Olympics of how, like, his wingspan is, like, body height is supposed to be proportional, and his hands are, like, the size of, like, dinner plates. I thought that was weird stuff that I was like, I found it last night, and apparently he, like, said in the movie that he also gets aortic chest diameter, which is what it's supposed to be. And they're like, so why do you get that? And he's like, just to make sure I'm healthy. And they're like, what's wrong if you have it? Like, yeah.
That's not you're not sure. You know, probably take away from his like image. It's like, oh, I'm genetically blessed, so I'm good at swimming. No, they want to get
Hey, make a mistake. It's one of my favorites.
Who should I bang it on? Myself, y'all can do that. How many of y'all watch The Walking Dead?
I haven't seen it this season.
Yeah, I haven't seen
I couldn't tell you anything, but I love The Walking Dead. It takes a while to get into it, but once you get into it, the zombies are just over here out of the way. This is the problem with the people. Oh, it's so good. So, do you watch?
Oh, no, I just have a question. What's your name?
Oh, no, we're talking Walking Dead right now. No, go ahead.
I was just looking at the calendar online. Is it done? Because there's a couple of days where there's just like, no, okay, right.
No, the calendar. No, for which class? Any class? No, the big blocks. Those when I sent y'all out that document to kind of list out, those were the big markers for things for exams and big stuff going on when there be SPBLs. But in terms of all the other class stuff that goes on, and of course, all of that stuff is not set, and it never can be because you're always dealing with outside teachers, and you never can just lock them down. So you have to kind of float it more. But in regards to Good Shepherd, humanities, SPBLs, exam days, start and stop of courses, all of that stuff is those are the rocks in the river that don't change. Okay, than the rest of that stuff. Okay? Unless something terrible happens, I have to envision something. Okay? Let's go ahead and look at, we're on page 7. We can get through some of this fairly quickly. Which dose and frequency should be used depends on the bug, how much is needed to kill that bug, the site of infection, the age of the person, the organ function, and the route of administration. And organ function and route of administration tend to run hand in hand. For example, a randomly eliminated drug in somebody with organ dysfunction of the kidney, it's a problem on what the dose should be. And you will usually have to dose down the amount and or the interval of administration. So for example, somebody with good kidney function, let's say we have antibiotic A, maybe that drug is 250 milligrams twice a day in a normal renal function person. In somebody with 30% renal function, maybe the dose is 125 milligrams QD, once a day. So you're taking the milligram amount down as well as the interval. And I'm just giving you something to think about, but the doses will be smaller and the intervals will be longer in general. Okay. Which route of administration is best? We've already kind of talked about that a little bit. You have to consider the site and severity of infection. Big. Patient's ability to take oral medications. Some people simply cannot do oral because they're too unreliable. So you have to go with parenteral routes with that person. Sometimes you hospitalize a person who's non-compliant for a period of time just so you get the infection arrested enough so that they can then go home and finish it off. But you would never send them home with a prescription for the antibiotic because you know it wouldn't be taken. They'll end up sicker and be back in the ER or admitted. Medication, oral bioavailability. What does that mean? What does that refer to? When you say bioavailability.
How much goes into systemic?
Yes. So let's say if you have 100% bioavailability of a 100 milligram capsule, how many milligrams is in that person's bloodstream? 100 milligrams all gets in. So the bioavailability for that would be described as what percent? 100%. Okay. And did she ever give y'all the designation F equal? Did you ever get that F? Okay, okay, just forget it. Your brain doesn't need that space. Just forget it. This is another marker, another terminology. But bioavailability is the percent of the drug administered that actually gets into the systemic circulation and into sites of action. Location of treatment, is it inpatient or outpatient? As we've said, oral therapy is generally preferred when possible because it cuts down administration costs and cuts down risk. When you're sticking people and messing around with needles, things can happen. Home IV therapy is an option, usually for stable infections requiring long treatment. I gave y'all osteomyelitis, prosthetic joint infection is another, endocarditis is another multi-week to multi-month treatment. Just very difficult because valve infections, they usually grow on, they're called vegetations. You'll get this in cardiology where they grow, there's scar tissue builds up around, they kind of get sequestered in there, and the antibiotic has a very hard time getting in there, so you have to treat a lot so it keeps going by and gradually sequesters in the site of infection itself. So just by location, it's hard to get antibiotic in there. And then other routes of administration, intrathecal. You know what intrathecal means? That's, say,
Into the CNS?
yes. So how do you think you get intrathecal administration? It's like doing a spinal tap. You know, you have to put a needle in and you put the medication directly into the spinal column. That's not an easy administration route. Well, I mean, that clearly is hospitalization, but that's a route. Intraventricular, into, you know, if you do a heart, you know, it's directly in there, and that could be done for, you know, that could be a heart, or it could be brain. So I mean, just getting it, basically what you're referring to is putting it directly into the cavity affected, and that can happen. Intraperitoneal, y'all know where that is, down here. You can get some wicked infections from GI surgery if you don't use the prophylactic antibiotics before and after the surgery. And once that gets going on, you really have to infuse, they'll infuse solutions into the peritoneal cavity so that it just floats around where it needs to float to, because it may not, if you take it orally, it may not diffuse enough out into the spaces to actually kill the infection off, so you actually go right into the site. Okay? So that's it. What is the appropriate duration of treatment? Varies a lot. Okay? For some infections, you have guidelines. Treat, you know, something for 10 days, for 14 days. It'll just be a guideline-driven thing. But some clinicians are going away from that. Let me just talk, I'm not going to test you on this, but I just want you to be aware of it. Medicine's not a set science in all respects. Things continue to change. For the longest of time, every patient was always told, be sure you take your antibiotic until every pill is finished. Don't stop too soon. Because the fear was, they take it 2 days to 3 days later, if you've got the right antibiotic for the right bug, let's say they have a throat, you know, a throat or some kind of upper respiratory infection, they feel so much better they quit taking it. Well, then it can overgrow, you know, grow back again. Maybe it becomes more resistant. There's that thought, or they never get it arrested in the first place. So we'd always say, be sure you take everything until it's done. Even if you feel better, don't stop taking it. Well, now there are people who are saying, and just I want to be interested to see what the providers are saying as they kind of come through here, that using antibiotics for 14 days when that's what you were prescribed, even if you feel better after a week, is maybe contributing to drug resistance. That if you just keep it out there and you basically killed off all the bacteria of concern, then all you do is keep exposing other bugs to it so that they can mutate around it. Is that the right, I'm not telling you to do that, I'm just telling you that the art of science and the science of science is actually beginning to move in a direction where we may begin to see more customized treatments. I don't think you'll ever see it change for things like osteomyelitis or endocarditis. Those treatments are in time. They've been studied with a certain length of time. But for more ordinary infections where you're giving somebody 10 to 14 days run of something, that's beginning to be questioned. And it probably should be, but there will have to be good evidence that short lengths is not creating a risk. Let's just watch and see where that goes, okay? And then finally, minimizing antibiotic duration reduces colonization of resistant organisms, which is kind of what I was it's kind of an extension number 2. This clinicians following the patient's clinical response to therapy to determine appropriate interval is kind of what's going on with the notion that they can reduce colonization with resistant organisms. So they kind of are together. Okay. Is combination therapy indicated? This will be an issue for you mostly in inpatient settings. You see it some in outpatient. Usually we figure out what it is and we treat it with an antibiotic, and combos are not seen all the time, though there are some examples. I'm going to give you where they are. What are the advantages of using combination? And again, mostly for inpatient settings. It broadens antimicrobial spectrum. If you've got a mostly gram-positive antibiotic A and a mostly gram-negative antibiotic B, and you've got a mixed infection that has organisms with both characteristics, then 2 different antibiotics might actually broaden that spectrum and you can kill things off quicker. Okay? It's usually used in the following situations. Empiric therapy, where you have a severe infection and that might have resistant organisms, you kind of want to just cover it all. Some people call it shotgun off the get-go, just to be sure you covered everything: anaerobes, gram-positive, gram-negative, staph, MRSA, all that. Mixed infections, multiples, or severely immunocompromised patients. In the severely immunocompromised, you really don't quite know what you're dealing with all the time, so a broader spectrum of coverage is perceived to be a safer thing than just one thing for one bug, and other stuff may get away from you. And they're such at risk for fatal outcomes with bad infections that you might see that. Another advantage is antimicrobial synergy. Sometimes the efficacy of 2 together is better than either alone. An example is enterococcal endocarditis. That's one where penicillin plus aminoglycoside actually works better. It kills better than either alone, and if you looked at what A did and what B did, it's more than plus and plus. Okay, it's a synergistic combination. So the combo for that particular disorder is a synergistic one. They work more powerfully than either alone. Trimethoprim, methoxazole, Bactrim, it actually is a combo therapy from the beginning. It is a synergistic combo product put together. You don't have to remember the details of this, but do you remember what Bactrim does, just broadly? Okay, just hang on.
Is it folic acid?
Say again?
It's something like folic acid. Or
It does. It's that tetrahydrofolate reductase. That's one of the enzymes affected. It's affecting the process that leads up to. Let me say, but you're on the right track. It's a cell line process, and each component impacts different enzymes.
Is it DNA?
Is it DNA or RNA?
Are you asking or telling?
I'm just asking. I'm just letting y'all explore.
Sulfur, because it's the fluoroquinolones, the M1, and then the sulfites. So it's
Do y'all remember? Y'all brain dead?
Yeah.
If it's not a red blood cell, you don't remember.
I don't remember those ones either.
What?
Blacked
What?
out, it's gone. I think it's
Okay.
DNA. We're gonna go DNA. Final answer.
Final answer. We'll give you some credit. I'll take a look at it. They affect 2 different enzymes in the process, and that goes towards making folic acid, remember? And there's 2 different enzymes in that step, and each one hits a different one, so it's a more powerful shutdown. So it makes it hard for the cell to actually create protein and other nutrients inside the cell. So it's a combo synergistic agent. So it's synergy by design. And it's actually set for certain ratios to do. Pseudomonas maybe, and their synergy is useful, maybe not, there's controversy about that. Prevention of resistance is another advantage. There are some situations where using synergistic combinations of antibiotics actually is more effective than not at preventing resistance. Tuberculosis is one, and y'all will get TB here, and you will hear of the cocktails that are used, and different combos are used for TB originating from different parts of the globe. All TB is not responsive the same way to the drugs. So there's some, if you get TB exposure in like a Central American country versus TB from a Southeast Asia country, the combos might vary because they're going after how TB has mutated in those areas. So they use combos for that. But those are some examples. Another one is Helicobacter pylori infections. Do y'all know what that is, H. pylori? Do you know what that's associated? What's that?
Ulcers.
Yes, that's right. A lot of times, sorry.
I doubted myself, I'm like,
It's a bacteria that's associated with developing the peptic ulcer disease, and it is actually treated with antibiotics. I remember growing up, we didn't think that was the case at all, and then we treated it with antacids and H2 blockers like Tagamet, cimetidine, etc. And then they figured out, oh, we can just kill the bug and then it's gone. And how do they do that in clinics? There's like a test, that little H. pylori test.
Blow in the bag.
Yes, that's right. Breathe in, and they can check it. So there are quick ways to figure out whether you're H. pylori positive in a clinic situation, so you can put them on the cocktails. Did y'all do that a lot?
Yeah, a little bit.
Okay. Yeah, you'll see it, and it's fairly commonly done. The disadvantages of combo therapy are several. You get additive drug toxicity. Vancomycin and aminoglycosides both enhance nephrotoxicity, so if you use them together, it doesn't mean you can't, but you have to monitor very carefully for the adverse effect. So one disadvantage is additive toxicity. Another disadvantage is increased risk of colonization with resistant organisms. So even though in some cases the combo prevents resistance, like in TB, there are some cases where when you shotgun across the board, it allows some organisms to outgrow it, and you get a more strongly resistant bug. So I'm not trying to confuse you, but all bugs are not the same, and all antibiotics are not the same. So there are cases where synergistic combinations are helpful at preventing resistance, and there are some cases where combinations actually enhance resistance. Okay, and then drug inactivation or antagonism. There are some antibiotics that when you use them together, they don't work as well as either one alone. I'll give you one example. Their penicillin and tetracycline is not generally a good combination. And I'm not going to ask you to remember a combo. There are some that don't work as well together as they do separately. And then if you put multiple drugs together, cost is the disadvantage. So just to review, the advantages are broad spectrum, a synergistic effect for some, and a prevention of resistance for some types of infections. The downside, more toxicity, additive toxicity, colonization of resistant organisms, drug inactivation, and more cost. Okay. How does antibiotic resistance factor into the equation? Well, complicated. It's certainly it's a media attention item these days. But the two ways is that you can end up with treatment failure, and you can end up with increased morbidity, mortality, and healthcare costs. That's the problem with increased resistance, is are we slowly moving our microorganism population to the point that we won't be able to treat things that we once could treat, and will that create a pandemic? You know, you've seen the movies where you get infections from some virus and things spread. That's really what all the big fuss is about. What if we end up with a methicillin-resistant, super-resistant Staph aureus that's just on the skin that gets out into the population and wipes out the population because nothing will kill it? That's the fear. Now, we worry about viruses by doing, flu vaccines and things like that, so you don't have these big spreads around the world, but it's also feared for antibiotics. That's why you hear all the hullabaloo about using antibiotics to treat meat. You know, if we eat meat from animals that were fed grains and antibiotics, will that be in our system? And will that somehow lead to more resistance patterns in the world? We don't know, but it's a public health issue. It will not go away in your lifetime, and it will probably become more intensely focused on as we know more. The one thing you know about microorganisms is this: they multiply so rapidly that any mutation to their advantage is going to spread real fast, and organisms have been doing that since the beginning of time, okay? And they are not going to stop unless the whole genetic world collapses on us. What we've been told is not true.
I can say something about animals and antibiotics.
Sure.
Because they have to have, like if you take an animal to slaughter, they have to have no antibiotics within a certain amount of days. And like at every kill plant, there's like FDA and people there to approve to make sure the meat and everything's good. Even going through like the organs and stuff. So I know that they're trying to be, I guess, safe on like animal meat products and stuff wise, because they have drawbacks for the animals, and if they're not in that period, then they can't be slaughtered.
You know, it's like everything. There, a controversy arises. The evidence is not clear in any direction, but it's suggestive. And so, depending on what side of the political spectrum you're on, it becomes a big issue in agriculture. Farmers will not be for it in general because it helps them with their productivity and aids them in positive ways. And then if you're a medical person who's very much a zealot, you know, for antibiotic resistance, then you might be against that. So it's, the truth is somewhere in the middle. It's neither, I don't think it's an either or. I think it's both and, but with knowledge about what you're doing. Contributing factors, overuse of antibiotics in the world, we've seen that. That figure is kind of interesting in 2A. Up to 50% of antibiotic use in hospitals is inappropriate. I'll verify that. There's a lot of inappropriate prescribing that goes on for long periods of time that don't help, not helpful. And then use of antimicrobial prophylaxis in immunosuppressed populations. Well, if you're doing that to prevent them from getting infected, obviously you're exposing populations of organisms and immunosuppressed people to an antibiotic, so they have opportunities to mutate against it so that the drug doesn't hurt them. So you're in a rock and hard place. Don't treat them, let them get sick and die. Treat them, create resistant organisms, and then the rest of the world's exposed to it. You know, what are you going to do? Okay, prevention and control, it's a multidisciplinary approach. Health systems all by requirements have to monitor antibiotic use and antibiotic patterns and antimicrobial patterns in their facility. Do y'all know what JCAHO is, the Joint Commission? I don't know if y'all been involved or not. Just for your fun, the Joint Commission for Accreditation of Healthcare Organizations is the federal entity that comes in to look at a hospital. Every hospital has to be looked at, surveyed, and they look at everything in the hospital, and one area focuses safety, and the safety goes to antibiotics and how that's monitored, and cleanliness techniques and sterility and all of this. If a hospital does not do the things well that the JCAHO says they must do well, then they won't receive certification. If they're not certified, they can't collect reimbursements from insurance or from Medicare. So it's a big deal, and if you work in a hospital, you will find yourself involved in getting ready for Joint Commission inspections, whether you want to or not. They're just so unfun to deal with, but you have to or you can't get any money. So they got you. I gave you a couple places, judicious use of antimicrobial agents. There's a Joint Commission website. There's one on antibiotic stewardship and monitoring programs. There's usually an infection control team at a hospital, nurses, pharmacists, physicians, laboratory personnel, and they inspect premises and come up with policies and monitor, and you'll be exposed to that. Okay. Developing new antibiotics is fun, but it takes time. And as soon as you develop a new antibiotic, you have a new antibiotic that can then, a bug can become resistant to. So you try to stay ahead of them, and we keep developing antibiotics, and we'll keep doing that. But the evolving nature of the microorganism makes it difficult to ever really win the battle. You gotta stay even or a little bit ahead. Okay. How should you monitor patients' response to treatment? Well, it's pretty obvious. A lot of the things you evaluated to determine the head infection is what you monitor to see if they're actually getting over the infection once you've declared it. So you're always looking at effectiveness of treatment. That's how you monitor. The first thing you want is you want to be sure that if you treat an infection with an antibiotic, the infection gets better. Second thing is you want to be sure that the person is safe, that you haven't done harm to them over the course of time. So you're always monitoring for effectiveness, and you're monitoring for safety. Doctoral testing says all the time, you want the good things without getting the bad things. And it's always a balance of the good and the bad. You want to be a prescriber that is maximizing good and minimizing bad. If you're 50-50, then you probably are costing more than you're helping. So you got to get it like that. Okay? Clinical improvement, straight up, the same parameters used to diagnose. So if you look at the clinical signs and symptoms, the diagnostic studies, the radiologic improvements. And B is the more important fact. If you don't really get a clinical response within 2 to 3 days of an antibiotic regimen, then you really need to explore other options. Why is it failing? What else needs to be done? And what's the number one reason an outpatient person does not respond to the therapy prescribed? Non-compliance. And what is the rate of non-compliance with oral medications in the outpatient area? How high? Give me a number.
100%.
70 to 80% is what they, 70 to 80, probably 100% of people don't take it perfectly right, but you know, maybe miss one dose in a week. But it's like 70 to 80%. So when you're talking to somebody about using a medicine, you have to know that 4 times out of 5, they're not doing it like they're supposed to. I know it's scary, but you can't dismiss it quickly. Okay, you have to always be thinking it. Another thing, number 2, the potential causes of antibiotic treatment failure: select the wrong drug, doesn't have the right spectrum, don't give it the right directions, they get malabsorption. Let's say somebody has Crohn's disease, some bad malabsorption problem in the GI tract, and you try to treat them orally. Well, maybe not going to go there. Okay, maybe not going to work. And then subtherapeutic dosing, inadequate dose. So you want to make sure you get the drug that will affect the organism at the right dose for the right length of time. Drug interactions can cause problems. I gave you some earlier. Let's say they're taking the antibiotic that doesn't like to be mixed with antacids, and they swig antacids periodically because they're a smoker and they have burning in their throat, type thing. And poor penetration into site of action. There are other host factors that can explain failure. Immunosuppression results in inadequate host defenses to augment antimicrobial effects. So if you're immunosuppressed, you can't help the antibiotic. And sometimes there is a need for surgical infection, for surgical intervention, like an abscess. When you have diabetic people with diabetic foot ulcers sometimes, and they can get really ugly. Have you seen some foot ulcers? I mean, it is staggering what you can see. Some of those foot ulcers, you can treat them all day with an antibiotic, and unless you take off part of that foot, it will not get better. Because the circulation is so poor at the site of infection that even if you did an antibiotic by intravenous routes, it really isn't getting out there. So it's just like a pocket of infection that never gets antibiotics, so it can just keep seeding things backwards. So that's why amputations happen. It's simply because you can't really get antibiotic to the site where it is. If you have a big abscess filled with pus and microorganism, you often will not, they encapsulate, you may not be able to get any antibiotic in there, so you have to incise it, drain it, get most of that out, and then you can even lavage it with antibiotic and then treat it with a medication. So there's just depends on where it is and what's going on. I had one lady, I'll just give you one little story, it just shocked me. Oh man. Had this lady, diabetic lady, couldn't get her blood sugars under control, asked her every question on the man. Finally said, do you have any infections on your body that I cannot see? And she said, well, no. And I said, no, anywhere in your body. And she said, well, I have an abscess. I have a sore, like a boil. And I said, well, where is it? It was right over her anus. And it was just right there at the end of the sacrum, just right there at the very end. And I said, okay. And I said, have you seen it? What have you done? She said, well, I've just tried to treat it, and I've just been packing it. And I said, with what? She put like gauze and everything. And I said, well, how big is this? You know, what are you talking about? So I had her disrobe. I called over one of the attending physicians. I said, yeah, look at this. There's actually a PA over at Health Science Center. I said, I want you to look at this. So we got her up there, got her to disrobe, turned her over, and I think we both about threw up. She had, I mean, seriously, she had an abscess that was probably, the outward was probably about dime size. Okay, so that's pretty big circle. And so took alligator forceps to pull out this gauze that she had put in there, and we pulled, and we pulled, and we pulled, and it was gauze out about this long because she just kept packing stuff in there, and it was all just gross. I mean, just totally gross. And I said, okay. We walked out and I said, well, that explains it. There will be no way to get her diabetes better. There's no way unless we get this treatment fixed. So we did pack it with dressing, put her on antibiotics, and did all the things we could do, and she finally did get better. But that is a lesson. If they're just sitting there telling you stuff, I want the details. What are we talking about? I've had people with a little boil that they said was no big deal up on their thigh. Where is it? Show it to me. That alone right there, that'll blow up your diabetes control. Total. You never be, I mean, 250, 350 all the time. Cannot quite get it down. So, Lord have mercy. That was just terrible. That was surgical, and almost surgical intervention. Yeah.
My uncle's had his toes on one foot amputated and his toes and metatarsals on the other foot amputated because they couldn't get his ulcers under control.
You can't do it.
And he's diabetic and he doesn't take his medicine.
If you don't have vascular supply to tissue, it's very difficult to heal that tissue. That's why they'll do debridement. They try to debride it back to the place where you find healthy tissue, because that then can heal and granulate and fill back in. So if you don't, you won't go away. Okay. Then also microorganism resistance, another reason for failure. Drug toxicity, we talked about those adverse effects. Changing renal or hepatic function interferes with clinical drugs, which can lead to toxicity. Is the toxicity manageable, or is a modification in drug therapy needed? Well, that'll always be the question. Do you have something equally effective that's not as toxic, and you have to make a change for that? Okay. Final thing here, should the antibiotic regimen be changed based on response? Couple of things to think about with your antibiotics. IV to PO switch may be considered, and IV to PO switching is a very common program in most hospitals because it's less expensive to go from IV to PO, and it's safer to go from IV to PO. So if you're trying to improve cost and improve safety, then you make those switches. Okay. If clinical improvement is evidenced by being afebrile for 24 to 48 hours and there's a decreased white blood cell count, that means there's a good response. Okay, and they've done it IV, you've had no fever for 1 to 2 days, and the white blood cell count's going down, then you might be able to make a switch over to a PO medication. They have to have a functioning GI tract. If their gut is atonic and it's not moving for whatever reason, you can't put pills down there because your absorptive powers are lessened, and so you won't get absorption. And then the final thing, the antibiotic chosen has to have good oral bioavailability. You see a lot of Cipro and Levaquin used because those are about 90 to 100% absorbed in the body. So the IV is 100%, but the oral is almost 100% too. So if they've got a good gut and they're doing better, then you can move on to the oral of those people, and then that's safer, and you can probably get out of the hospital faster too, to do that. Okay, and they gave you a couple of examples. I gave you the fluoroquinolone. Okay, therapy de-escalation is a term you need to be familiar with too, just to think about it. But the definition is after starting a broad spectrum empiric therapy in order to avoid inadequate initial therapy, and you finally know what the bugs really are, then based on lab results, you can tailor it back. That's probably the biggest reason for inappropriate antibiotic use in the hospital setting is starting empiric therapy because that's right and you have to do that, but then getting results back and not reconsidering the regimen. You may not need all that stuff you got on board. The clinical thinking is this: well, I put them on this and they're doing so much better, so I'm just going to leave it alone. That's actually admitting to ignorance, because if you've got a culture sensitivity and you've got the shotgun approach and you know it's a gram-negative enterococcus and you've got an antibiotic that covers that in your shotgun cocktail, and you've got things that are, you know, that are gram-positive that really don't make any, they're not adding, you have to get rid of those things. So once you know, then you tailor down. To know and just go, well, they're doing okay, so let's leave it alone. That wastes money, increased risk for toxicity, and increases risk for resistance patterns to develop. So think once you have something to think about, and don't just let stuff float around. Some approaches: you can discontinue one or more being used in combo. Switch to an alternative agent. Sometimes you can switch to one agent once you know what the drug, what the bugs are. Sometimes there's one agent that will cover both things, and that's better than three things covering pieces of it. So you just go to one, and that's considered okay to de-escalate. So de-escalation is pulling off things you don't need or streamlining down to the fewest agents possible that are effective. That's de-escalation. In the prescribing world, nobody goes backwards anymore. If you've got 10 things, we add an 11. If you're going to put the 11th on one, you get rid of 1 and 2. It just, you will see this in practice so often, is that whatever's on there must be for a reason, and I'm going to take care of this new problem. You have to look at them very specifically. What's the reason for this? Is it helping? If you don't know why it's being used, you know if it's helping, why is it there? It's just like chemicals floating around in the body for no good reason. I can always strip a drug regimen out. I can make a person's regimen cheaper today because you can't prove what's needed. You can't prove it, you don't need it. And if it's not, you can't prove it, it's not documented, that's bad care too. You know, you need to know what you're doing with all the drugs. Okay, benefits of de-escalation: reduced duration of antibiotic use, decreased risk of resistance, reduced toxicity, reduced cost. The flip side is therapy intensification. Okay, when there's a treatment failure or a non-response, you have to get with the program. Broad spectrum antimicrobial agent can be added as adding another antibiotic to the current regimen or selecting a new with a broader spectrum. When your culture comes back and you aren't covering for everything and you kind of got a partial response, you need to re-envision that regimen for something that makes some sense. Usually, your report will give you suggested approaches that might be useful. You might say, oh, they're really sensitive to so-and-so, let's go this road and get rid of these 2 that don't work as well. You can add or switch to an antibiotic with a different mechanism of action, or reevaluate causes for treatment failure, that is administration, compliance, synergistic actions with the drug that inactivates it, toxicities, all of those things that you might want to review. Okay, so we're going to stop with that. Just to review this thing, just hold this. You can look at this from time to time. I want you to have a little bit better background underneath about why people do what they do. I need you to be better than it's this disease, we use this drug. It's not wrong to have disease and drug. It's not wrong thinking. But I need you to understand more so when things don't go as expected. You can evaluate it, have an idea of what's going on, and be able to contribute. Okay? Okay, we'll let that go. And I'm so sorry for the long day. I really am. I really have to be. Maybe if I come out and see it, I just feel bad.
I was like, why do I keep saying
I know.
He's like, I really like your last name.
Yeah.
down, they get the star into the realm. That was scary.
That was a good game.
I need a
Surprise.
And you got Harry Potter at the door.
Yeah, that was like so weird.
Isn't that funny?
How like this is
Yeah, and that guy looks like Harry